Thank you very much. I must appreciate Dr. Manu Harsh for speaking for a few minutes but telling his mind. I think the answer all of us know as we carry on growing age-wise, not maturity-wise, we start realizing that the response to the stress is more important than the stress itself. So we should learn how to respond to the stress. I know the bells were ringing again, and he could do an justice to his presentation. Thank you very much. And now we are going to have a session on bariatric surgery, current scenarios. And I bring greetings from Sir Gangaram Hospital and Bhatia Global Hospital. And I am fortunate today that I have Dr. Randeep Wadhawan, who is the current president of ASI, Dr.Atul Peters, who is with us from Max, Dr.Ashish Vashishth, again from Max, and all of us know Dr.Subhash Aggarwal, so I should not introduce him. Now, in this next 25 minutes, what I am going to outline my panel discussion on, first thing is disclaimer, that I will ask them all questions which are coming from your side and I am presenting to them. And I would try to take the juice out of them as much as possible. And because the topic is such, bariatric surgery current scenario in totality, so I will be touching about evolution of bariatric surgery. But again, I must request you, warn you, that please do not give the long answers. Give the short, crisp answers so that we are able to finish off in next 25 minutes. And evolution of bariatric surgery, then patient selection and pre-surgical assessment, that is very, very important, especially in bariatric surgery, and advances in surgical techniques, whether one is married to sleeve gastrectomy, to gastric bypass, to mini gastric bypass, or some other procedures, and what are the outcomes and long-term benefits. And today, in spite of the fact that all of us are practicing bariatric surgery for last maybe 2.5 decades, but still that much awareness is still not there, or patients are not coming forward on their own. You see the quantum of surgery which has been there in US and which is there in India, you will see the difference. We are not even, as president of ASI, I would tell you that we are not even crossing 10,000 surgeries per annum. So that means we are creating more fear. And Dr. Randeep Wadhawan, I would ask you that first, most important is why in India, as compared to the world over or as compared to US, we have not been able to create awareness in the minds of the people, then they start coming for the surgery rather than begging. They should earn their surgery as early as possible and get the maximum benefits. What is the reason behind this?
Thank you, Dr. Bhatia.
Mic on, please. Give the mics. Yeah.
Thank you, Dr. Bhatia, and a very good morning to everyone. And thank you for the invitation. You're absolutely right. The numbers are huge. So we look at our population of 1.4 billion. The data by the Family Welfare Department is that we have 5% obese. 5%, you multiply that into 1.4, roughly about 7 crores. The number of bariatric procedures that we are doing are somewhere around 17 to 20,000 bariatrics, and we are kind of stuck there for the last probably 3 to 4 years. We've not increased in bariatric numbers. And awareness, yes, fear of getting a surgery done. So one is a fear of getting a surgery done. People still have that fear that they may go, they may never come back. The morbidity and mortality associated, which was earlier there with bariatric procedures, not anymore, not in centers of excellence, but they still have that fear factor. Number two, I still feel insurance coverage is still not adequate.
That will come later on. Dr. Atul Peters, do you think that the fear factor is more, or we have been not able to push the surgery? As simple as that.
So both are true. Fear factor, yes, and also with people acceptance of being obesity not as a disease as such. So fear and not accepting their own problem, which is obesity. Two important things.
Sure, Dr. Ashish, I know that you have been a proponent of laparoscopic bariatric surgery and now you are doing robotic bariatric surgery. I'm not going to ask you about laparoscopy and robotic, but what do you feel? What is the present scenario and the future scenario of endoscopic sleeve gastroplasty or endoscopic procedures? Are they going to come and replace your laparoscopic surgery, replace your robotic surgery, or something new is going to come?
See, endoscopic procedures in CRISP, if you want to say that, will always remain. But for some redo kind of a surgery which has been done bariatric, if you want to tackle some weight gain and all, it's a primary procedure. It leads to almost 10 to 15 or 20% of the weight loss, so that's not going to stay. Basically, all bariatric surgery, whether you do a sleeve or a bypass or MGB, is going to stay. And what I like to say, why the patients are not coming, because the results are very variable. Every surgeon who is doing it, is doing it and he has to do a gallbladder, so he has to do a bariatric. He doesn't understand how the procedure has to be done. So when the results are not good, society, because the gallbladder gets you gallbladder, hernia gets you hernia. So if your results are not, in some surgeons, bariatric surgeon who has got good result, they are doing good bariatric surgeries because they have good results.
Sure.
So I feel the results are not up to them.
Dr. Subhash Aggarwal, what do you feel? What is the commonest procedure in the world and in India which is being done, which is being offered for bariatric patients?
Sleeve gastrectomy.
Sleeve gastrectomy. And initially, when all of us started, then gastric bypass and sleeve were comparing with each other. But we have seen the difference, and world over, the trend has been the sleeve has become the commonest. Those surgeons who were doing maybe 8 to 10 gastric bypasses, for example, Philip Shower or any other great surgeons, they have also converted themselves into sleeve surgeons. Why? Why do you think so? Why it has been there?
Because in surgery, whatever procedure we have, one, it should be easy to learn for the surgeon. Second, if you give the results which are comparable with any other procedure, it is definitely bound to last. Secondly, because the normal passages are preserved, so patient feels as if he is as normal as he was before the bariatric surgery, particularly when it comes to the sleeve. And results in the best center, in the good hands, are very much comparable.
Sure. Dr. Randeep Wadhawan, you have... Yeah.
Secondly, Dr. Ashish also said, I think we should emphasize the problem comes when we talk about re-surgery in bariatric.
We will come later on. Yeah.
Yeah.
We'll come later.
So because of that fear also, when the patient gets re-operated, this message goes because he could not get it controlled and had to undergo the surgery again. Naturally, it dissuades the patients.
Dr. Randeep Wadhawan, you have been again proponent of sleeve gastrectomy and then gastric bypass, and now you advocate more of mini gastric bypass. What is in your mind that are you having some thoughts that you had failures with sleeve gastrectomy or with gastric bypass, and you have lot of successes with mini gastric bypass? In 3 sentences, conclude that, please.
So first sentence is that why all the procedures give you the best results is because it depends on the compliance of the patient. So we've seen when we are only talking about bariatric surgery for weight loss. For weight loss, sleeve, OAGB, RYGB, by and large, if the compliance is good, they'll invariably lead to almost similar kind of excess weight loss at the end of 3 or 5 years, and that's why sleeve is a common procedure. Number 2, second comment, you said why any of these procedures? Now they change because of the indications. Sleeve may not be the best procedure as a metabolic procedure. When I'm looking at a patient where we've got 70 million diabetics in our country, and a diabetic comes with obesity, I would not offer a sleeve. I would offer one of the bypasses. So that's my second. Now why third comment, somebody who comes in with a reflux and obesity, I would offer a Roux-en-Y gastric bypass. So my indications change, and once the indications change, that's when the procedures change. But again, last comment, if it only is for weight loss and you're looking at a good compliant patient, then any of these procedures would work the same.
Very nicely done. Very nicely explained that ultimately we should be married to one, but obviously we should know others also. Dr. Atul Peters, do you think for patient selection, as he has rightly pointed out that patient is having diabetes, patient is having reflux, I will offer them the gastric bypass, otherwise you are for sleeve gastrectomy, or is BMI important today also?
Of course, yes, sir. So BMI is important as one of the primary factors to mark. It is easy to learn, easy to reproduce, and also it is important for the reimbursement processes, for hospitals, for the patients, for GPs, to understand a common standard or a standardization wherein patient selection can be done. So BMI is important. Is it the only factor to be taken? No, but it's important.
Ashish, what is the role of investigating the patient thoroughly, and or you will go in for endoscopy, you will go in for sleep study, you will go in for pulmonary function test or not?
So there is a gradation according to the patient. If the BMI is very high, definitely all this like vascular, Doppler, and PFT and TSC and all has to be done. Endoscopy is a must, because if you don't do endoscopy, you don't know whether the patient is a hiatus hernia or a reflux problem. And to my thought, 70% of the surgeries are done sleeve. So if you are doing a sleeve and you don't repair the hiatus, because the person doesn't want to do a bypass, person doesn't want to do it. Everyone cannot do a bypass. Please understand that. Why 7? And you don't you think that 70% of the patient will not have hiatus hernia? So I feel endoscopy is required. So all these tests are required in all the patients. To my thought, you should not. This is a surgery, this is a lifestyle surgery, and it should be taken as any other surgery. So I feel all tests should be done, including arteriovenous Doppler of the thing.
Thank you, Ashish. Ashish, please go ahead.
Yeah, I'm extremely sorry to interrupt this panel discussion, but it's 12 o'clock now, and as you know that 12 o'clock is sacrosanct time for the general body meeting. But as I can see that the quorum is not complete, the quorum needs to be complete as per the constitution, so we'll be delaying by around 15 minutes, so we'll have the GBM at 12:15. Sir, may I please ask you to continue? Thank you so much.
Thank you.
Sorry, Chairperson.
Thank you very much, Dr. Ashish. And now I would request Dr. Ashish that you have been doing laparoscopic, you have been doing robotic. In what category of BMIs would you advocate robotic, or you will offer to one and all for robotic?
See, it all depends. See, preferably one will do robotic if the patient wants, can afford it. But why robotic is better, at least the super obese, when you're doing more than 50 BMI, it is the ease of the surgery. And with this stapler short form which has come and all, the angulation is so good that if you're doing a sleeve also, you are doing a perfect sleeve. There is a perfect hockey stick which you get it. If you do a perfect sleeve also, it adds to it. And at the end of the procedure, you have to see the comfort of the surgeon. He's not tired at all.
Sure.
He can do 2-3 surgeries in a day.
Right.
So I feel AI is very different. AI is associated.
No, I'm not asking you AI. I will ask him. This paper has leaked.
Yeah. So I feel if
No, I am asking.
If given a chance by the patient, we will prefer doing a robotic, but lab is also very good.
I am going to ask Randeep Wadhawan, is there any role of AI today? Once we have mastered our laparoscopy, once we have mastered whatsoever robotic, and then comes the new cup of tea, and that becomes AI. So should we carry on unlearning, learning, and relearning, and up to what time we will carry on unlearning or learning?
So I feel that AI is going to be integrated with robotics. So going
Will or has been?
already
It already has been.
integrated with. So that's where AI will probably come in. It will guide you when you are doing a procedure. So there's a new robot which is going to be launched, and this is, I saw the prototype, and this is by J&J along with Google by the name of Verb, and they have integrated completely in the sense it is going to guide you that this is where you can go, this is a full stop, or this is a red line where you can't go. So that's where probably it may help.
No, in the same breath, I would say that Da Vinci has also, my son is in Da Vinci in San Francisco, so he has told that Da Vinci 5 has already been launched in US and it is showing, but again, one has to have a rider. It shows that as we follow the GPS, that you take left turn, then you will see the CBD. And if you take the right turn, then you will see the cystic artery. But most of the times, at the moment, AI has progressed so much, you have already injured the CBD. So that is also, so what I mean to say, please do not use the AI, do not lose your natural intelligence also. So cling on to the natural intelligence as well as to the artificial intelligence, then only it is going to make a difference. Dr. Subhash Aggarwal, do you think that along with the weight loss, other parameters, other outcomes of bariatric surgery, they are going to push and become the metabolic surgery, or it should only be, we should carry on selling only about the weight loss?
No, definitely, because the initially, of course, it started with the weight loss surgery, but later on, over the years, when it was realized the metabolic, it has become a metabolic surgery because there is a resolution in the diabetes. The drugs are either patient is off or it is reduced. Similarly, even for the hypertension also. So, and other things like joint pain also. So naturally, it's not only metabolic or weight loss, but beyond that also, because other things have also taken care of by the bariatric surgery.
Sure. Randeep, if you compare the laparoscopic sleeve gastrectomy, gastric bypass, mini gastric bypass, duodenal switch, where do the resolutions of the comorbidities stand for? For example, as you have rightly mentioned, if the patient is having diabetes, the resolution will be maximum after gastric bypass. And if the patient is having reflux, yes, gastric bypass. So how do you compare at the time of maybe 5 years, maybe at the time of 10 years?
At the end of 5 years and 10 years, we know that the bypasses will do a lot better for metabolic syndrome, which is type 2 diabetes, hypertension, cardiovascular risks, and dyslipidemia. So in these 4 categories, any of the bypasses will do a lot better than the sleeve. Weight, I've already mentioned, by and large, they are similar. Total weight loss at the end of 5 years or 10 years would be roughly similar, maybe a little more in the bypasses, but not statistically significant as compared to the sleeve. So sleeve and bypasses would be similar, but resolution of comorbidities a lot better in the bypasses.
Why do you say, Atul, why do you say that still any of us and every of us know that in long term the bypass has the better resolution, but still the sleeve gastrectomy has become the commonest procedure? Why?
First of all, sir, it's because of the ease of the surgery. Younger surgeons, more centers picking it up. Sleeve is a much easier, reproducible. So more and more surgeons are picking up sleeve. So I think that is one of the important reasons. Secondly, if it's done purely for weight loss and not for resolution of comorbidities, and majority of the people who are coming for bariatric surgery are coming for weight loss, not really resolution of comorbidities. So patients desiring of weight loss, ease of surgery, newer surgeon picking up surgery. So that's one of the reasons why sleeve is becoming much more common than the bypass.
Wonderful. Dr. Ashish, what has been in your tenure of maybe 3 decades of 2.5 to 3 decades of bariatric surgery, what kind of challenges or risks you have faced, or you have seen, or you have heard, or which should become deterrent, especially to our younger surgeons?
First thing, it's very important to prepare the patient, because you cannot expect the medical complication which is happening. The first thing is that if you're talking about the surgery, then the use of staplers and the dissection is very important. There are various type of staplers, what you say, they're green and purple and all. And to be very frank, in the last 20 years, I'm not trying to propagate anything, but I don't think so the height of the stapler matter. If I use a tri-stapler purple, which I have used in a bypass and an MGB and a sleeve, and trust me, till date we don't have a leak. It has got the compression effect. How to use that is surgically very important. So if you use the stapler well...
Sorry. Do you think that the staplers misfire or the surgeons misfire?
No, it is the way to use the stapler.
Way to use the... So that means surgeons misfire.
Yeah, surgeons misfire. People use clips and the clips come in the thing. So there are a lot of bougies. You have to be how far away. So I feel the surgical technique is very important who wants to do.
Atul, I know you want to say something. Yes, go ahead.
It's not always the type of stapler that you use, but it is also, as you said, the natural intelligence and the tissue that you see. That is extremely important because, and so it's not a simple thing, it's not always the statement, but yeah, also the technique that you use.
And Dr. Randeep, in overall, in last again 2.5 decades, how many cases you feel in your practice would have earned the revision surgery? Because of the weight regain or because of morbidities, comorbidities? So what percentage of patients will ultimately land for revision surgery?
So in our practice, if I look at my case mix, I do about 6 to 7% of all my work is on revision surgeries for weight regain, for reflux, and for the metabolic syndrome coming back just because a particular procedure was done, or maybe a sleeve was done, and patient probably needed a bypass. So about 7%. And if I look at the US data, it's about 12 to 14% patients are going in for revisions. So that's roughly the data which is for revision surgeries for various things. It could be for anatomical issues, metabolic issues, or whatever.
Dr. Atul, if the patient has regained weight after sleeve gastrectomy, what is there to offer?
So a lot to offer. Number one, the most important thing is please investigate why he has regained weight. I believe there are 3 things, and I will be very quick. Number one is a surgeon factor, that means a wrong procedure for the wrong patient. Patient factor, patient was very non-compliant. And third is gut adaptability. So the gut or the body adapts to it. So if it is a surgeon factor that the wrong procedure was done, there is a lot to offer. You can re-sleeve, you can do bypass, you can do MGB, BJB, switch and everything. If it's a patient factor, I don't think so we should do anything for the patient, because if the patient is not ready to be a compliant patient, no matter what you do, he will meet with an accident again. And if it is gut adaptability that you've done a sleeve and you think that adding a bypass or adding some amount of malabsorption is going to help, then probably a SADI or a SADI-S would be much better.
Much better. And Dr. Ashish, if for example your gastric bypass patient has regained weight, his or her diabetes has started coming back, and other sleep apnea syndrome is also there, what are you going to offer after gastric bypass failure or maybe whatsoever you call it?
See, after gastric bypass failure, there are very less options if you want to offer. You have to first evaluate what was the reason for it, why did it gain weight, and all those things. What about the compliance and these things? Sometimes the gastric bypass and the intestinal bypass becomes a common territory. What is this endoscopic finding? Then you can decide a procedure, but surely the results are not good what we have seen after a conversion to any other procedure. The weight loss is not done.
So definitely one has to carry on thinking whether we are going to offer the revisional surgery or not, and whether we are going to give the benefit to the patient after revision surgery or not. That should be seen or felt by the surgeon, rather than if the patient is asking go ahead for next surgery, please restrain yourself, resist the temptation, investigate thoroughly, and then plan whatsoever is the best for the patient. Dr. Randeep, yeah.
On Roux-en-Y gastric, revision of Roux-en-Y gastric bypass, we are the only center which have published the Indian, we have an Indian publication in Journal of Bariatric Surgery. Not a big cohort, just about 22 cases. And like Ashish said very nicely, that difficult to convert these patients. What we have done is, we have actually trimmed the gastric pouch, put a ring around it, and distalized the limb, and that's led to some relief in weight loss as well as comorbidity.
Dr. Subhash, in a lighter vein, band का band बज चुका है या नहीं बजा अभी?
Band though still being used by some centers, but as of now, band बज चुका है.
So what I mean to say that there have been surgeons who have been propagating band placement, but ultimately Whitgrove was also very, very happy that all the bands which had been placed, it had already been taken out. So I am happy that it has been done. Dr. Atul, you also mentioned that if, for example, patient has weight regain and he or she has gained weight, and one can offer sleeve into re-sleeve, sleeve into gastric bypass, we per se investigate the patient thoroughly and we convert them into sleeve into SADI-S. So, do you think SADI is also a very radical procedure, which normally notion is, or it is not?
Sir, it is a radical procedure, and the patient must be counseled and understand that they need to be on lifelong supplementations, and an Indian subcontinent taking lifelong supplementation may not be all that easy. So it's a radical procedure. It should be a very informed consent and giving all things to the patient before taking it.
Sure. Dr. Ashish, this is the last question because I can see the organizers coming up with the... So I would ask you, in this scenario, in this era, now so many drugs are coming. So are you going to become redundant? Because of the invention or so many drugs are coming and so many drugs are proving themselves that they are having good effects. So ultimately, and can you imagine, today also so many patients from US also they say that buying the tablets or injections is very, very costly, but still we are doing it and we have lost it, but they have lost 15% of the excess body weight. So what is the position of the surgery when these drugs will ultimately develop, as we have seen with truncal vagotomy, gastrostomy? So it will be in the museum or no?
No, I don't think so. Both will go together. The pharmacotherapy and as well as the bariatric surgery, they are all friends, because that will prepare the patient for bariatric surgery in failure, because 90% will try drugs. But if you have a weight regain, and nowadays we are routinely using post-bariatric also after 3 to 6 months to get the best effect. So they both are going to work in association with each other.
Sure, thank you very much. Yes, yeah, please go ahead. How much balloon? Excellent question. Sorry, I missed it. I should have asked them. Do you think that the balloon works?
So balloon is good, and it is meant for class 1 of these without comorbidities. It is a temporary method, and the patient must be told clearly, number one, the weight loss is anything between 4 kgs to 20 kgs. For the first 2 weeks are difficult. You will regain almost 80% of the weight back once the balloon is out. You still want it, you can give it. So it's one of the options, but for permanent weight loss, for class 2 and class 3, for comorbidities, it is not a good option.
Wonderful.
It is largely promoted by the companies producing.
Wonderful. My answer to this is, many patients come to us and they ask for ballooning. And I say that yes, I will refer you to my enemy. So that, because let's be very honest about it, in the initial phase, when the balloon started, 750 ml of saline was to be placed in, and those patients will carry on making your life hell. Anytime and every time they were even taking liquids, they were taking semi-solids or solid, and they were having vomiting. So they were not at all bothered whether it is 1 a.m. at night or 1 p.m. in the afternoon. They will always give you a phone call. So our thinking is, as Atul has also rightly pointed out, after 6 months, balloon has to be out. And after 6 months, the weight regains and it bounces back. Thank you very much. Thanks a lot, my dear panelists. And thank you for allowing this time. Thanks a lot. Thank you.